हेलेक्स वेलगस। अब यहाँ पर बेसिक बात क्या है कि हम लोगों को समझना है कि हेलेक्स वेलगस क्या है. It is not a very
Should we do it in English, Mr. Sheikh, yeah?
Oh, okay then. Yeah.
Because there's a lot of international community watches later on, like, yeah.
That's right. Helix valgus is not a very difficult topic, but it is a topic that we all have to know what our aims are. When a patient walks in and has got a helix valgus, we have to know what are we aiming to actually treat. Just as you know that when we are walking, the gait of a normal the normal gait is a tripod gait though. Therefore, the first metatarsal head bears some load bearing when we are walking. In this helix valgus, that function of the first ray has been lost, and because of the function of this first ray is lost, therefore this will lead to the deformity, and this will lead to the transfer of that load, which is normally done by the first toe, will be transferred to the lesser toe, and that is known as transverse metatarsalgia, because the job of the first toe has been shifted. And when the deformity gets worse, then the plantar plate, which is a very important structure made by the sheath of the flexor tendons and by the sesamoid bones and by those ligaments, when that plate actually ruptures, then there's more of this, this deviation gets worse, and the toes, the lesser toes, can also become abnormally shaped. Yes. Now, so when we are seeing these patients, our aim is that we must try to improve the pain. The pain of this helix valgus can be of two types. One is known as extrinsic. That means when he is wearing some shoes, so the extrinsic pain can be addressed in different ways, and the easiest way is to give him this white shoes. And then there's one more, and then the pain is of two, and the other type of the pain is intrinsic pain. For intrinsic pain, unless the surgical correction of that big toe and the alignment is done, the intrinsic pain cannot be then resolved. So our aim of treating this helix valgus is that firstly, that we have to control the pain, and secondly, we have to improve this deformity in such a way that we can restore the function of this first big toe, so that we can maintain this tripod. And once this tripod gait is maintained and the load bearing part of this big toe comes there, only then we can improve this transverse metatarsalgia. So the idea of this talk is just for us to get a concept of that. So when we are seeing the patient, we should know that how severe the deformity is, and how and what are the best ways we have got to treat. The treatment, just as we know, that the treatment of all cases we have to always start with there is a non-operative and then this. But the non-operative and the operative treatment will always depend upon the assessment and how severe the case is. Now, so let us see all this. All these will give you the concept, and after this concept, then we will have to just discuss that what the various options are and what is the best way. There will not be a single operation that will suit them all, though. But you have to choose. So when we are appearing in our exit examination, you are a consultant there. So you have to know that what the diagnosis is, how severity. So you have to know the severity, the patient, the demand, the patient, the general health, and then you have to have a choice of a scientific treatment that you can explain, and you have to have a scientific reason. Now let's go with this. Now what that definition is, that this is a lateral deviation of the great toe and the medial deviation of the first one. So just as you can see that the great toe has turned a bit laterally. Now this as you can see on this picture is a left left, yeah, left side. You can say that the great toe, has turned there, and the first metatarsal has just deviated. And then with time, there will be a progressive subluxation of the first metatarsal joint. In all the cases of this hallux valgus, you have to see, when we are seeing that two things: how much subluxation of this joint is, and how bad is the arthritis, though, whether it is mild or too bad, because the severity of dislocation, because if it has gone too far, severity of this subluxation and the severity of the underlying arthritis will both affect your choice of the treatment when we come to that. Now, what is it? This is a static deformity due to the valgus angulation of the distal articular surface of the first metatarsal. We will just come to that. Now, there is not a single cause, though. There are many things, and therefore one of the important is, that in 70% of the cases, in these cases, the hereditary is important. Now, so just as you can see that the causes are, number one is metatarsus primus varus. If there is a metatarsus primus varus, that means that when you just draw the line between the shaft of the first and the second metatarsal, the normal angle of that is about 9 degrees, but this can be about 13 or 15. When that angle is markedly more, then that is known as metatarsus. Then yes, that is a hereditary component. In 70% of the patient can give this, then this can also be a part. Therefore, in pes planus, or there can be a tightness of the tendo Achilles. Therefore, the examination of the hind foot, whether there's a pes cavus or the so although it is a 4-foot deformity, but the examination, we must examine the whole foot at all times, because we have to make sure that there's no tightness there. And then there can be a ligamentous laxity that can play the role, and sometimes you will see that there is a hypermobility of the tarso-metatarsal joint, and that can play a very important role, and also that will then decide what mode of treatment to take. That hypermobility of the joint is more important when we're dealing with the juvenile. Then, because of some of the neuromuscular disease, footwear. Now, footwear, it says that if you are wearing the tight shoes and have got the high heel shoes, that can cause, and therefore, in the conservative treatment and in treatment of the intrinsic pain as such, the first will be the modification of the shoes. That means there will be a low heel shoe and there will be a wide shoe. So those are the important. Then somehow more common and fourth is 6th decade. So just so we know that one of the hallux valgus is known as juvenile, which we will just discuss. That the only important things to just discuss are that all these things just are the same, but the hypermobility of the joint is a bit more common than that. And number two is that when we come to surgical options about doing osteotomy and all that, so we have to see that if the epiphysis of the children is not fused still, then we may have to modify our treatment. But generally, the causes and the management and the treatment in juvenile and in all these cases, by far and large, it is the same. But we have to modify our way of treatment if the physes are still open. And rheumatoid arthritis, rheumatoid arthritis, this is because if in rheumatoid, if the tissues, they are not too good, if there is underlying osteoporosis, if there is dislocation of the joint, or there is dislocation, or if there's a growth, then our choice of treatment at this stage would be a little bit different then. Now, if there are any questions, you see, basically, the idea of all this talk is to give you this concept that what hallux valgus is, and 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 when we are seeing this, we should see the child or the patient just as a whole. And when you are examining this, although the hallux valgus is deformity of the forefoot, but the whole foot has to be examined. Next, this is just to tell you that the first metatarsal joint has got on the top. We have got extensor hallucis longus and this, and flexor hallucis longus, and then abductor on one side. And now, in all the deformities, we always have to know that what is deforming musculature here. So here the most important is the abductor hallucis, abductor, and then it is adductor hallucis. So these two are, but I mean, so this, therefore, when we are doing these deforming forces, they are actually important to know, because if the deformity is quite marked, then when we are doing a soft tissue release, then after the lateral capsule release, we may have to then sometimes release the abductor at that time. Abductor. Okay, then next one, then the two sesamoid bones, yes. It is very important to know that in hallux valgus deformity, when there is with the sesamoid bones, they go out of the place though. The idea of the sesamoid bones is to keep the balance, and to keep their main job. Main job is now these, the sesamoid bones. There are two bones here, and they are present in the tendon of the flexor hallucis tendon. And during our correction, we have to make sure that the fibular sesamoid or the lateral one, both the sesamoid come back to their original place, because the function of the sesamoid is that load bearing, that weight transmission, and for that adequate function of this tripod gate, the two sesamoid have to function well and have to stay within the line though. And these are two sesamoids which are there, and then plant there. Now plantar plate is a very important structure as such, because this is formed by the tendons of adductor and abductor joint capsule. If the deformity becomes severe, then the plantar plate can actually tear apart, rupture. And when it ruptures, there is a shifting of the sesamoid bone, and there is a shifting of all this weight transmission to these lesser toes, and that is known as transfer metatarsalgia. And there, now the question is that when you see these patients, when they ask you to be, if we do not get this operated, then what will happen though? It is not necessary that all of them will deteriorate. They will deteriorate, but we don't know over how long. But we all know that when once hallux valgus has developed, what you can tell the patient is that this will not get better. It may get worse with time, and we cannot accurately judge how long and how soon and how severe the condition will be within what time. But we can tell them that this is not likely or this will not get better. Now then, here there are, I mean, all these lines, just so you know, these two important lines are just here. Just because this is a line you have to draw in the center of the diaphysis of the proximal phalanx. One more line here, center of the shaft of the first metatarsal, and this is what is known as the HV angle for hallux valgus. Normally it is less than about 15, but I mean 15 to 20 or 15 to sometimes say about roughly, because there are so many different ways, but the easy way is the 15 to 25. They normally called is a mild. 25 to 40 they normally call it is a moderate, and if it is more than 40, that means that this hallux valgus is a severe disease. Number two is important is here that if you draw a line between the shaft of the first metatarsal and the shaft of this, then this line, this is known as intermetatarsal angle. Time is normally less than 9. But if there's a metatarsal adductus varus, then this angle can be a bit more. But if this angle is more than about 15 or 20, especially if this angle is more than 20 degrees, then the distal osteotomies alone on its own may not work very well. So to know the intermetatarsal angle in the hallux valgus is actually important, because if you just if you have got a hallux valgus of mild to moderate degree, a distal osteotomy based at the metatarsal head may work well though. But if there is an intermetatarsal angle which is very wide, which is more than 15 to 20, then this may not work. Then the distal osteotomy on its own may not work then very well. Right. Then we come down to clinical presentation. Now, when the patient comes to you, the common complaints are that either he has got pain, or he will say that he has got this bunion which is rubbing against his shoe, or he would say that he has got this prosthetic deformity. Normally, a young girl, if they've got an adolescent hallux valgus, their main complaint may be that they have got this prosthetic deformity. The common cause, just as we discussed, that the pain is either extrinsic pain or is intrinsic pain. The extrinsic pain is because of all this pressure of this footwear and being a bit too tight or toe box, which can be released by external means. Intrinsic pain or intrinsic pain, the only way that will go is by a surgical intervention. Now, so this pain can, and number two is, just as you know that at the metatarsal head on the medial side, there is a bursa there, and that bursa can become thickened. And this bursa thickening, this metatarsal head, and this irritation of the skin, which becomes hyperkeratotic. All these things combinedly, they form what is known as a bunion. So bunion is a combination of this thickened skin, underlying there is a bursa, and then underlying there is a metatarsal head. So all these combinations they form this bursa. And then, if this becomes worse with time, then you may know that there is some skin breakdown. And can also be. Now, bunion, so what is a bunion? A bunion, just as we discussed, is a prominence of the metatarsal head overlying subcutaneous bursa and this thickened skin on the top. So the pain can come of all these things, all right? Then this is, what is this? When this is left, without treatment, it can lead to the pronation of the big toe with time. Now, when you're seeing this patient, then you must examine, and when you see that on the skin, you must see whether there are calluses or there's what, and then the site of the pain, and then the magnitude and all. And this is, at that time, it is very important to see how much motion they have. You have to see that whether it is subluxated, it is dislocated, and whether there's motion or not. Because if there is some motion and the arthritis is not too bad, if it is subluxated but not totally dislocated, then still we can do some salvage operations. And then lastly, you must see that there is a metatarsocuneiform joint for hypermobility. Normally, there will be some mobility up to about 9, but if the mobility is far more, then we will have to just think about a different kind of But this hypermobility of the metatarsocuneiform joint is important, especially when we're looking for the juvenile and those patients who have got a hypermobility as such. And then when we come to the treatment, this will be treated in slightly different ways. And then you have whether there is any passplantar deformity or contractures. Because if these are there, then they have to be appropriately treated. And the mobility and structure of the whole foot and then the gait. So all these things have to be seen. Now, You have to do the X-rays though, and most important is a AP X-ray and the lateral X-ray, because on the AP X-ray you can measure this hallux valgus angle, and then the DMMA angle, and then the intermetatarsal angle, and you have to also see how bad the arthritis is, and the AP will also show you how much is the subluxation or the displacement of the sesamoid bones, and the lateral view will show you how bad the underlying arthritis of the first MTP joint is. Because if the first MTP joint is markedly arthritic, then we may have to think on a different way of treatment. Then you have to assess for the bone and joint deformity, and then the length and shape of the person. Now, length and shape, it is important to know that in our treatment, maintenance of the length of the metatarsal is very important. If the metatarsal, if we do any operation that loses the length, then if we lose the length, then the function of the big toe to act as a tripod stand may be lost. And the patient may end up with having a transverse metatarsalgia, whereas our original aim was to treat in such a way that the alignment of the big toe has been maintained and the function of the big toe, so that when there's a tripod gait, the big toe, the first MTP joint is acting as one of those tripods to carry that weight. If that is lost, then so our primary, then you see whether it's a congruent joint or it is an incongruent joint. Actually, if it is an incongruent joint and there's a mild and moderate deformity, even then the osteotomy described, they will work well. But if it is severely incongruent joint, or if it's dislocated, or it is markedly arthritic joint, then we will have to think about different modes. Osteoarthrosis, yes. And then forefoot alignment is always checked whether to see how bad the metatarsus adductus is. And you, just as we did say, that although it is a forefoot deformity, but we have to examine the whole foot. So we have to examine the hind foot, whether there is any pes planus deformity or a pes cavus. And therefore, when we were talking that what can be the different causes, so among that we did say that there could be some neuromuscular causes. So neuromuscular causes that cause pes cavus or pes planus that can lead to the hallux deformity as well. Now, hallux valgus. Now, just as you did discuss that this is a line, the hallux valgus angle is drawn between two lines. A line passing through the shaft of the first metatarsal and the line passing through the shaft of the proximal phalanx. This is known as hallux. And the normal angle is about 15. And just as you did discuss that, then there's mild, moderate, or severe. So most of them say 15 to 25 is mild, 25 to 40 is moderate, and more than 40 is a severe. Similarly, then there is known as intermetatarsal, just as we discussed, that is between the shaft of the first toe and the shaft of the second toe, and that is known as though normal is about less than about 9 degrees or so. And with primus metatarsal, primus varus, this will go more and more, because as this first metatarsal will become adducted more and more, this angle will become wide. It's 9, but that it will become 15, 20, or 30, and then that will become moderate or severe. So if it is 11 to 13, that will be known as mild. 13 to 20 is then moderate, and more than 20 is then severe disease. So if it is moderate or if it is a severe disease, this is so wide, then just doing an osteotomy at the distal level may not work. You know. Then it is a distal metatarsal articular angle. Also, although it is a big name, but I mean all it means is that a line drawn from here, from the center, yeah, and then this is a line on this is a line which is perpendicular or not, just parallel to the articular surface head, and then you draw a 90-degree angle to that line, and this angle formed is the DMMA. Now, what it shows is they just showed that there is a lateral tilt. There is a lateral tilt of the distal articular system. In some of the, if this angle is not too bad, then in distal osteotomies, things can become corrected. But if the intermetatarsal angle is, very wide, if you're doing a proximal, then many of the proximal osteotomies, this angle can become worse though. And therefore, in some of the proximal osteotomies, you may have to do a distal osteotomy as well, a double osteotomy to have a alignment. So if there is an intermetatarsal angle which is very wide, and you end up in doing a proximal osteotomy for the correction. So proximal osteotomy, you can calculate by doing that, can sometimes make this angle worse. And if that's happening, then you may have to do a distal osteotomy as well. That is known as a double osteotomy, double first metatarsal osteotomy. And then we have got this proximal phalangeal. Now this proximal phalangeal articular angle is just, this line drawn here and then a line drawn here, and then just to see that how much tilt is there. If the tilt of the proximal phalanx is marked or more than 15 to 20 degrees, then you may need a osteotomy, a medial closing wedge osteotomy of the proximal phalanx. That is known as Aiken's osteotomy. So we will come to the whole treatment is just not very difficult, but we have to know the basic concept that once you are there, how to do a osteotomy and a soft tissue release to get the balance, to get the sesamoid bones within line, to get the angle of the first metatarsal within line, so that we develop a tripod, and we avoid getting the transfer metatarsal here. Those are the few important. Now the severity, just as we had discussed, that it depends upon the hallux angle is less than 20, or 15 per se. Then normal, just we had said, it is 15, but from 15 to 20 is mild, 20 to 40 is moderate, and this way. And just as we discussed, between the first and second intermetatarsal angle normally is about 9, but 11 or less, 9 to 11 is mild, then 12 to 15 is moderate, and 16 or more. Now, as we said just in many books, it says 11 to 15 is mild, and then up to 20 is moderate, more than 20, but here it says about 12 to 15. But just say that most people agree that if it is more than 15, then a distal osteotomy on its own or alone may not be able to correct that, and will need a proximal approach in those cases. Then subluxation of the lateral sesamoid bone, that you have to see that how bad it is, less than 50 or 55, or how bad. Now the treatment options are non-operative and operative. All patients should be treated non-operatively first, despite some people will need insight. Now, in an examination, when they have asked you to discuss in general, then of course always good to say for the treatment or management of any condition that it always is non-operative and is operative, though. The non-operative is, in this case, there has to be a modification of the footwear, and there will be a widened toe box, so that to decrease the lateral deviation of this big toe, to decrease the inflammation of the area and the pain, to decrease the heel height, because the high heel, what the high heel does, it pushes the foot forward. So when you decrease the height, it will just stabilize it, will not allow the foot to go on forward and to become tightened or crowded in the toe box. So the crowding is avoided by keeping the foot rather than leg in this way. And then so if there's a pes planus, then you might give them some article. Now, if the Achilles tendon you find is contracted, then you have to do some stretching exercises. If it is very contracted, you may need some lengthening at the surgical treatment. Now, so what I was saying that if in the exams, if they show you an X-ray which has got a severe hallux valgus, don't spend the next 10 minutes talking about the conservative treatment. I mean, because we all know that in a severe hallux valgus, the conservative treatment will not work. And therefore, it is very important that if you want to mention, you can say that the treatment will be conservative and operative. But looking at the severe condition, the conservative treatment is not likely to work. And my plan of treatment in this patient would be A, B, C, D. But don't say this toe box and all this conservative management that we have discussed. If he's talking about general, if he's showing you an X-ray of a severe hallux valgus, and you spend the next 10 minutes in talking about shoe box and blah blah, and that is not good. That's not. Because he is wanting you to come out with what are the surgical approaches. And when you come out with those surgical approaches, you must know the sound principles of how it functions, what its complications are, what the problems are, and what is your ultimate aim. Our ultimate aim, just as you know, is as we had discussed, improve the pain, correct the deformity, and to improve the transfer metatarsalgia, and to bring the foot back into a tripod stand gait so that it acts as a weight-bearing area. That is our aim. And of course, when all this will be done, the bunion will be lost, the pain is gone, and then it will look nice as well. So I mean, all that cosmetic deformity, but that is our primary aim is pain, deformity, and making it function well like a tripod, and avoiding the transfer metatarsalgia to our primary aim. So if it shows you a severe disease, then talk in that way. Okay. So what are indications? Now, indications are persistent pain. It is not cosmetic complaints, but sometimes, I mean, these young girls in juvenile, one may have to just. Number two is the progression of deformity. Just as we said, it's difficult to quantify how bad it will be within 1 year or 2 years. Nobody knows. Nobody knows the natural history that the valgus, hallux valgus will become so bad in so many years. But the one thing for sure, it will not get better. Whatever the condition is, it will get worse. But how long? When? We don't. But it will not get better on its own, though. Hallux valgus does not resolve spontaneously. Then there's a failure of it. And our goal is to protect all pathological elements and yet maintain a biomedically functional forefoot. So that's the thing. Usually it will not result the foot with a normal, I mean, it might not look completely normal though, because the osteotomy has been done and there are 2 scars and blah, blah. But it should be good enough so that when the patient is walking, he is weight bearing in a tripod way, not having pain in his lesser toes, and there's no clawing of the toes. Because what happens with the plantar plate ruptures? It'll be clawing of the toes. So there's a hallux valgus, and then the big toe becomes pronated, and when sesamoid bones are moved laterally, and then stress on the plantar plate, as we saw, plantar plate ruptures, and that will cause shifting of and deformity, bony deformity of the lateral, and they will all become clawed. So that's all a severe case of a hallux valgus. Now, so usually it will combine soft tissue procedure with bony procedure in almost all cases. I mean, Mr. Shah has said we should keep our language as English at all times. But all I want to say was, if anybody has questions, or if because you have to develop this concept. I mean, now we have come to treatment, so maybe that after this treatment has been done, then if you can all talk, because unless you all talk and show what the conception are or what the you must talk though, you must talk. And then okay, let's go to the treatment now. Now, soft tissue, distal soft tissue reconstruction. Medial and lateral procedures. Hallux valgus angle is less than 30 degrees. IMA is less than 15 degrees. But but in soft tissue reconstruction, like if you're doing a McBride procedure or a lateral release, bunionectomy, and lateral release, still the chances of that are recurrence is high. And some note as 50%, some is more if no bony procedure is involved. And medial and lateral procedures at the same time, they are contraindicated. The idea of the contraindication is that if they are done extensively on the medial and the lateral side, then you may strip the soft tissues to a great extent, and there can be avascular necrosis of this metatarsal head. So, I mean, extensive lateral and extensive medial release at the same time can lead to A, it can lead to the avascular, and B, if you are dividing the tissues on the lateral side too much, then that can lead to sometimes to hallux varus deformity as well, which is very difficult to treat. Now, the medial procedures are that we tighten the lax capsule. The capsule is then normally you just take a V shape of capsule and then advance the capsule and do the plication. And the AB ductor should not be then detached. AB ductor, we just, yeah, medial side. Then lateral side, capsular release, adductor longus release, adductor longus release or transfer. Now, if after the capsular release, which is basically this, the suspensory ligament between the sesamoid bone and the proximal phalanx itself. So there are some suspensory, but all the ligaments and all these are not well-defined structures as such. Many of them are just thickening of that capsule, which have to be then released in a longitudinal way. If you give a vertical cut may cut the collateral ligaments. And if you cut the collateral ligaments, it can lead to a hallux varus deformity. It is very important. But if after those cuts, still you are not able to get a good correction, then only adductor longus release or adductor longus transfer can be done. Because just as we did a study that adductor longus or adductor, this is one of the important deforming force in that. One of the very important deforming force. And then the division of the metatarsal ligament, that is then the deepest. If worst comes to worst, or if it is very tight, so he has given them all in stages. Doesn't mean that all these have to be done. It does not mean that all these have to be done. It is your judgment at the time, but it doesn't mean that. Then this he has shown all this, operation here, and then the treatment is the bony now. Now, distal metatarsal, he has shown Mitchell's osteotomy, Wilson's osteotomy, Chevron osteotomy. Now, I must say that Mitchell and Wilson's were very common osteotomies and very widely used when I was like you, a trainee about 40 years back though. But now I think at least in the last 20 years or so, so maybe that this procedure here is mentioned that it should not be done. Because if today in this day and age, if we say Mitchell's or Wilson's osteotomy, because primarily they will shorten the big toe. They have got their own complications. But the biggest thing that we're taking a piece of bone out. If it shortens the big toe, then it will just defunction that primary part. So although they were very widely used up to maybe last 20 or 25 years ago though, and we used them a lot in all cases during but these procedures are not and should not be mentioned unless the examiner asks you, and then you should say that they were widely used in the past, but then they had number of problems, and including the major that they will be shortening of this first ray, and therefore it will essentially defunction and will not restore our primary aim of this operation in restoring the tripod stand and the pain and the deformity. And because it will be a short toe, it will not stop you from getting or progressing to the transfer metatarsal. So these Mitchell's and Wilson's there. But Chevron's osteotomy is now very widely used. Chevron's osteotomy is a very widely used osteotomy. It is V-shaped cut, inverted V-shaped cut, given distally, and naturally Chevron osteotomy can be done proximally as well and distally. But the commonest for a mild to moderate, in mild to moderate cases means when the IM angle is perhaps up to 15, not more than 15, and the HVA angle is up to 35, then the distal chevron osteotomy works very well. You just cut that chevrons, and then there is a V-shaped cut, and then you have to move the metatarsal head laterally. And then some people will just leave it, but most of them will then fix it with one screw, which has got a differential pitch, and normally that takes about 6 weeks. 6 weeks to just heal well. So that is a very widely used osteotomy. But if this intermetatarsal angle is more than 15, and certainly if it is more than 20, if it is a severe disease, then you have to address proximal. Address proximal, and you can do a chevron or a crescentic or a different types of osteotomies proximal. Now, when you are doing a proximal osteotomy of the chevron type, and then moving, because the idea is to move the first metatarsal close to the second one, but intermetatarsal angle has to be decreased though. So when you're pushing that like this, sometimes the distal metatarsal and articular angle may get worse, and therefore with a proximal chevron or proximal crescentric or a proximal osteotomy, you may have to add a distal osteotomy as well to correct the DMMA at the same time, so that the alignment is well maintained. We will come down to that. Oh, where are we now? Proximal crescentic, distal. Here. And then, just as we had discussed that in phalanx, if there's interphalangeal angle is there, and the phalanx is just tilted medially, so that the phalanx itself, there is a deformity in the proximal phalanx itself, which is adding or contributing to the hallux valgus deformity, then we can do an Aiken's osteotomy. Aiken's osteotomy, where you can cut this feet, and then you can do a medial closing wedge osteotomy. Here you are. This is an Aiken's. This is here. There he has shown you an Aiken's osteotomy. Cut this wedge, and then you make it straight. That becomes a closing wedge osteotomy. That's known as Aiken's. That can be put either. Then you can hold it with either a staple, or some people put a screw across. Both those work well though. But you have to know the basic thing. If there is an interphalangeal angle as such, and there is a deformity in the proximal phalanx itself, which is adding to the hallux valgus deformity, then we have to add the Aiken's procedure to this. McBride's, as we know, it is this lateral release, and as we said, it is the capsular release, and you do the longitudinal cut and not the vertical cuts, because the vertical cut has got a risk of cutting the collateral ligaments to vascular cut. And after those ligaments, then you may have to release this adductor, and if it is very tight, then you have to release a deep metatarsal ligament. It has to be done stepwise. And then this is just a bony exostosis which we have to done, and this is a chevron. This is a chevron's cut, which has to be a V-shaped cut at this level. Mitchell's osteotomy, I mean, just so you know that now, many people, I mean, just, right, okay then, right. Then this is a distal osteotomy which were done proximal. This is proximal eccentric osteotomy. Then this was what we said, that if you are doing the proximal chevron and make the distal angle worse, then you may have to do a double osteotomy. And there it looks like so well. And this is our surgery. That if the HVA is less, and then the procedure is modified McBride's, or the distal, then we can do. But however, if the angles both become bigger, then a proximal osteotomy has to be done. Complications are that this may become recurrent. There may be a hallux varus, pronation of the body, pain, neurological injury, osteonecrosis, and physeal arrest and non-vision. And that's it. Now, what are the questions? Do we have any questions, or maybe this? Yes,
yes, sir. I do have a question.
bit long.
Before you start, just a question. Tashfeen Saab has joined us. He's one of our foot and ankle surgeons from Aga Khan. So
Oh, right.
Tashfeen Saab. And before anybody asks a question, I want to summarize this as a shoulder surgeon who has got no interest in feet. So basically, when you see an exam case in feet, you need to make them walk first. You need to make sure that you look at them from the front, middle, and behind. You need to make sure that it's got a tripod gait. Now, if he has a tripod gait, then you need to make sure that the deformity that is correctable and non-correctable, because the treatment will depend if it's a correctable deformity, a soft tissue herb. You will then also need to make sure the joint is normal. You can't do all these surgical procedures if the joint is not normal. Also, when you want to correct it, you have to know whether the deformity is moderate. And if it's a moderate and severe deformity, you may consider a proximal osteotomy or sometimes a double osteotomy. If you have all this in mind, the procedures you can add on, but that is your basics concept of a bunion to save the exam. You're more than welcome for ask questions now.
Sir, would you? My name is Kazim. I'm from Indus Hospital, Karachi. My question is, could you please elaborate a bit more about the modified McBride procedure? I couldn't understand it completely.
Modified McBride procedure is just a soft tissue procedure. It is only for a soft tissue release, which have to be done when you give a longitudinal incision, which is the first and the second toe, and then you just release those strictures there. All those ligaments which are actually mentioned within those textbooks, but the ligaments are the condensation or the thickening of the capsule itself. And what it says is that when we just release, we try to release them in a longitudinal way rather than release them in the transverse way. Because by releasing the transverse way, sometimes you might end up damaging the collateral ligaments. And number two was that beside that, there is a tendon of a adductors. If after the soft tissue release and after the capsule, if the lateral structures are still very tight, then we may have to release this adductor. Yeah. And then deep down to that is the metatarsal ligament. That can be divided, or that can be released only as a third stage. So that doesn't mean that in McBride procedure, all the structures have to be released at all the time, but you have to judge each time how much release is actually needed. That would.
Can I ask one question as well?
Salim sir.
Yeah.
Salim sir,
Thank
you should tell us the answers though.
So can I answer that modified McBride condition, yeah?
Yeah.
So,
I need to ask. Yeah, please carry on.
So when you have an operation that has been written by a surgeon, it is under his name. When somebody does a modification to make it a better operation, it is called a modified McBride. That doesn't mean it is not the same procedure. So, for example, if you use a stainless steel suture and you're using Ethibond or whatever suture, then it becomes a modified procedure. It is not the same procedure. So just remember that modified does not mean there are two different procedures. Just somebody done a small modification, not cutting this and not cutting that, that makes it a modified. But it's exactly the same procedure somebody described. Unfortunately, it is not doing the same things as it was originally meant to.
Right, sir. Thank you.
Awesome, sir.
One simple question. Hello?
Go on, ask.
Yeah. In deformity, moderate and severe, the most commonly done osteotomy in UK is scarf osteotomy. So Sheikh Saab did not mention scarf osteotomy.
Well, I mean, all these things from mild to the severe can be addressed with Aikens and with a scarf. A scarf osteotomy combined with the Aikens osteotomy can address all the hallux from top to down though.
But it should have been included in the list.
No. It is a presentation to stimulate you to go and read. Mr. Sheikh, in 40 minutes cannot tell you everything.
Okay, that's fine.
Yeah, but you're absolutely right, Mr. Salim. Scarf is very cool.
Answer is
thank you.
Yeah, Mr. Shah has answered, but more is because I personally thought that I am taking a bit too long. But when you are mentioning the osteotomies, then in UK scarf osteotomy combined with the Akins can adjust the helical wear from mild to the most severest cases. And lastly, there's just one thing to say that if there's a bad arthritis or if there's a failed operation, then arthrodesis of the MTP joint is also, I mean, yeah. So a very
Sweet, do you want to make a comment?
No, I fully agree that scarf and an Akin does solve almost everything. And there is a difference in the approach in the US versus the UK. In my visit to the US, what I found was that they are much more inclined towards the lapidus. Their philosophy is that the underlying problem is the IMA, which is the varus of the metatarsal, which is the driving force for the subsequent development of all the other elements of the hallux valgus. So treat that first. They have a very low threshold. While in the UK, what I saw was that they reserve that for mostly patients who have hypermobility of the first ray and these generalized laxity patients.
By Tashwin sir, UK में, you are very right that lapidus procedure is only limited to either those juvenile cases where there is a hypermobility or in the grown-up cases when the Batten index is high though. And if the child has got physis growth rate which is still open, then rather than doing this lapidus with this, they will do a medial closing wedge osteotomy of the cuneiform. And then number two is that with this lapidus, because the DMA may get worse, therefore some people may add with the lapidus this distal two things. Magar, in UK generally, lapidus is not done as an operation of the first choice. It is only reserved for those two cases, either severe hypermobility cases or in juvenile cases.
I have one question. Can I am Arif Ali, resident from Aga Khan Hospital. I had one question. If a transfer metatarsalgia complication occurs as a result of hallux valgus correction, then which procedure should be done to treat that complication?
I mean, the whole idea of this operation, if it goes correctly and has done well, then the whole aim of this operation is to prevent or to correct the transfer method, so that you have gone back to the, a tripod stand. But if you're saying that the transfer metatarsalgia is still there, that means this operation has either not been corrected or the operation has actually failed. Tashwin sir, what are, yes, after view care, what is your view?
So can I say something? The thing is that you just mentioned that when you do an osteotomy, especially like a Mitchell's, you shorten them.
Yeah.
And therefore
Yeah.
the tripod gate, although you've had a very good surgical option, it has not been corrected. And if you can't correct it, your transverse metatarsalgia will persist. So that is not a complication of the surgery, but it was there before the surgery and the surgery has not corrected it.
Yes, that's true though, but yes.
The tripod gate is very important. You have to have a gate where everything is normal. Although I am not a foot and ankle surgeon, but I did my training as a Birmingham rotation and I worked with Mr. Plews. Mr. Plews was a very old-fashioned foot and ankle surgeon. And he used to do the Mitchell's osteotomy, but he used to do something different. He used to do a modification. He used to do a lengthening Mitchell osteotomy. So you do an X-ray, and if the big toe was small, he'd actually lengthen the cut, not do a straightforward step, but a lengthening step. So even in that time, they were still talking about the length being right. But I mean, a lot of better operations, such as a scarf and everything, has turned up. But in those days, he used to do a lengthening, and he'd never put a screw in. He'd put a stitch into it, and he told me never to X-ray because they look a lot worse.
Well, my experience is only with the scarf, and I haven't done any Mitchells yet. Well, I was trained in that with Dishan Singh, with whom I did an attachment at Royal National. And so, but something which is similar to Mitchell's, which I saw the Americans doing, was percutaneous correction and fixation with an extra osseous K-wire. Now, that appears exactly like the Mitchell's, where you translate the distal third or so of the metatarsal towards the lateral side. So you see a step there. And that again can be modified, as Dr. Munawar said, by making it oblique. You can have a lengthening or a shortening or you can plantarly translate or dorsally translate and fix it accordingly.
Okay, any more questions, guys?
Dr. Munawar, I would like to ask you one thing.
Gosh,
Can
not
you?
for an ankle. I may not be able to answer your
No,
question.
I understand. You summarize a very basic point with respect to with respect to the exam,
Yeah.
right after the presentation. Could you repeat that?
Yeah, sure. So when you see a person with a foot and ankle exam, you have it two ways of having it in the exam. You can have it as a prop on a PowerPoint presentation for you to see on a table, or as a clinical patient. So every time you must mention gait. You have to start every examination of the lower limb with gait. So do have a gait, comment on the type of gait, then become an actor. Sit in front of the patient, sit in the middle of the patient, sit on the side of the patient to see what the forefoot is doing, what the midfoot is doing, and what the hindfoot is doing. Now, if you see a hindfoot deformity, then you can say that the predominant deformity is a hindfoot deformity, right? And therefore, I would like to do this. However, if you exclude everything and it is a forefoot deformity, then you need to make sure that it is correctable or not correctable, i.e. it's a flexible or a non-flexible deformity, right? So if it's a flexible deformity and there is no arthritis and it's moderate to mild, a soft tissue on its own may help you. However, if it is a moderate to severe, which is correctable or non-correctable, an osteotomy has to be done. If it's a very severe deformity, then a proximal osteotomy has to be done. Sometimes a proximal combined with a distal osteotomy. Even sometimes you have to do a soft tissue procedure with these to correct it. So it's called an a la carte correction, which means you have to get a tripod gait and you correct whatever needs to correct to make the foot look normal in the tripod gait. However, the key, like you play games, you have a cheat code. The cheat code here is do a sliding osteotomy and a Lapidus procedure all at the same time, and that will be your answer to nearly everything. This is God's gift to orthopedics in feet, where you do a scarf with a Lapidus, and that will answer all your questions. But the way to say an exam is gait. Then you need to know if it's tripod or not. If it's tripod or not, you need to know where the primary deformity is. You need to know whether it's correctable or not correctable. If it is correctable and it's not arthritic, you can do all these corrections, proximal or distal. However, if it's arthritic, then you have no choice. You can't do many corrections with arthritic, only make the shape better, but you have to fuse the joint.
Right, sir. Thank you. Thank you.
So, to generalize, it is very important. If the hallux valgus deformity, if it is common, if in Pakistan it's common, and you are getting moderate to severe cases, then as Tashfeen Ahmad has said, that scarf osteotomy and Aikens combine, or they can resolve. Just by reading through the textbook, it may not be able to learn those. You must go to Tashfeen Sahab and learn that, because you must know, okay, where those cuts are and how those cuts are done. And only if you do that osteotomy properly, you will save yourself from complications. So Tashfeen Sahab, you should teach them and train them about that.
Yeah, Tashfeen Sahab is very good. He joins us every time we go for an ankle service.
It is a good operation, but it's something that you have to learn. You've got to learn. And if you know, okay, cuts and the biomechanics of that operation is very important to learn. Very important.
It's a very technical operation, and a lot of things can go wrong.
I think so. Yes. Absolutely. Yeah.
We must be sure what we're doing.
Yes, right. Absolutely right. Absolutely.
In the current and model world, everything is gone electronic. Maybe Tashfeen Sahab should put a video for an osteotomy, so we can all learn from it. Then, isn't it? Yeah. Okay. So,
sure.
Guys, if you are all happy, we can call this a day. I was hoping to teach you gait today, but Mr. Sheikh actually.
No. I think Mr. Shah, next time I will reassess 2-3 times so that we finish it in good time, because this took too long.
So I was told that people have an attention span of 20 minutes. Anything beyond that,
I agree with that.
Anyway, it is a good lecture. We learned quite a lot, and lots of stuff was basic stuff that you need to know. In the exams, nobody wants you to cure people. Everybody wants to know that what is your thought process, and basics are getting more and more in the exam. You need to know basics, not what operation you need to do. Okay, good. So the other thing you must also remember is, if there is surgical option not valid, exact like the patient is not fit for having a haircut or is not fit to have any surgery, then orthotics do play a role. You can have a big toe box shoe for them to have no pain. You can put something to take the callosity pressure away. But operation is not the be all and all of everything, and the patient has to be fit enough to have one before you can operate. That's okay. Remember, you can't do any surgery if there is arthritis of the joint. You can talk about it, but all these osteotomies have to have a nearly normal looking joint, which unfortunately in our part of the world is not common. Most of us come to hospital when they're burnt all option, Peer or Fakir or Damdrud, sab karne ke baad aate hain, Tashmin Sahib will tell you. So it is not as easy as you and I see on the books in England. अब अपने शायद नूर साहब कहते थे पप्पू मरीज नहीं आते हमारे पास डिफिकल्ट मरीज आते हैं.
Very true. Very true.
If everybody's happy, we'll call it.
Can I ask a small question? I may have missed one part of that. If I can ask.
Yeah, of course.
If the MTP joint is incongruent, I may have missed that part. If the MTP joint is incongruent but not arthritic, then which is the procedure?
There is no straightforward answer. Mr. Sheikh will tell you, but you need to know where the deformity is. Does it need proximal correction or it needs a distal correction? Yeah.
If the joint is incongruent, then with all, as Ashwin Saab said, even then this scarf osteotomy will work very well. Only if the joint is dislocated or is arthritic, then you have to consider arthrodesis in those cases though. And callus operation, though it is mentioned, but it's not a good option, except in the very low demand elderly patient who are not fit. Otherwise, callus operation should only be just mentioned as a salvage operation. But arthrodesis should be considered if the joint is totally dislocated, if it is osteoporotic, if it is a salvage operation, and if the previous operation have failed, or if it is grossly arthritic. But for subluxation of mild to moderate nature, still this scarf treatment should work well. Tashmin Saab, what's your view?
Yes, once you've done the scarf, it corrects the deforming forces, and the joint tends to come back into this normal position. And when the DMAA is too much, that means there is a tilt of the joint that can very easily be corrected with an Aiken.
Yes.
Just out of curiosity, for all the people who are visiting, staying here, why was Keller's popularized? What was the reason, and where did it come from? Does anybody know? Keller's procedure. तो मेरी अब जो है ना वो स्टेज हो गई कि नॉर्मल किताब पढ़ने के बजाय एबनॉर्मल किताबें पढ़ते हैं. Who and why, what they did it, like I said. So Keller's arthroplasty was designed for the army. The army's general surgeon, किसी को जो है बनियन हो गया, जूते में वो वॉक करते थे, उसको ट्रबल होता था, उन्होंने Keller's करके कहा जाओ शाबाश शूज पहनो, वापस जंग मैदान पे चले जाओ. So it was a quick fix for young military men. Right, what it did to them later on was a totally different story. However, this was the army's answer to bunions for putting the soldiers back onto the field. However, we don't do it anymore. It's now a procedure for salvage only. Anyway, good. It was a good discussion. Thank you, Sheikh Saab. Hopefully, we'll join us soon.
Thank you, everyone. Thank you.
So the video will be on the forum after we finish, and hopefully, we'll all have a look at it again. Yeah. Thank you very much.
Thank you.